I am delighted to introduce two fabulous physicians. Do you like how fabulous physicians? That's my new name for you. Dr. Nick Christian, and you've already had a chance, most of you, to meet Dr. Carlos Tirado. I will just mention again that Dr. Tirado is the CEO and founder of Karma Health and an addiction psychiatrist. Dr. Christian, who I'm blocking here, Dr. Christian is an internal medicine physician, and I'm just going to editorialize for a moment and say the impact of having general medicine, internal medicine work in the area of substance use has been powerful, and some of the greatest work, quite honestly, no offense to my psychiatry colleagues, is coming out of general medicine and internal medicine. So just great to have him here. And he is the, oh, I'm sorry, I don't have your title here. You're gonna have to, oh, you're with Community First. You're gonna have to introduce yourself because your bio is a little different than I was expecting. But I will tell you that he is an internal medicine and addiction medicine clinician and researcher for the Office of Clinical Director for the NIDA Intramural Research Program. He completed his addiction medicine fellowship at the Yale Program in Addiction Medicine, as well as a postdoctoral research training at the VA. So we're delighted to have him here as well. He's a friend of Austin, and it's great to have him here. Excuse me.
All right, let's do a mic check. Are we working? Check. All right, we on? Not yet. Almost there.
I got it.
Almost there, check. It was working moments ago, as it always does. If not, I will.
Why don't you start with that and I'll turn.
Yeah, that sounds great. Awesome. Yes, thank you, Jennifer. It's great to be back in the place that honestly inspired me to go into addiction medicine. So great to be here in Austin. I did my internal medicine residency training just down the road at Del Seaton Medical Center. And I'm currently a staff clinician at NIDA, and I just have to share in the beginning that I am discussing all of these items today. They're all opinions of my own personal capacity. They do not reflect anything of the NIH or the US government. And apparently Carlos also wanted to disclose that. I didn't realize that got added here at the slide, that his opinions also don't reflect the National Institute of Health.
No. No. They don't.
The talk today, Carlos and I were joking about this earlier, is it really, it's kind of a way to hype people up about the future. It's also kind of a buzzkill because we're going to talk about some really amazing things that we probably won't see in the clinical realm for a little while. But I hope, just like how Chandran was talking earlier this morning about how it's hard sometimes to focus on the positive things and remaining inspired in our work, I hope that throughout this talk, this continues people's motivation and hopes for a brighter future in the field of addiction medicine. So with that, our learning objectives today, I'm going to start by talking about the GLP-1 receptor agonists. If you have no idea what that term means, no worries, I'll explain it all. And then I'm going to hand it off to Carlos. He's going to talk about some psychedelic-guided therapies, as well as a therapeutic device. And if we have time, I'll do a little rapid fire of some other things that I've seen coming down the pike that might be of interest to everyone. Does anyone want to try to announce this name for me? I don't even know if I can. Psychoneuroendocrinologic therapies. So that word really entails the set of drugs that I'm talking about here, the GLP-1 receptor agonists. So we're going to start with a question. In 2023, what % of Americans received a prescription for a GLP-1 receptor agonist? That's semaglutide, liraglutide, exenatide. For people that aren't in medicine, that's Wegovy, all of the huge weight loss craze medications. I don't know if we're doing this on Hoover, so I will just reveal the answer now. 1.7%, so nearly 2%. I think that we were supposed to have about 200 people in this room, so that means there's at least 2 people in this room who are on this medication. And I did also want to note that I cannot announce the company, the maker of the most common formulation of semaglutide, but they're based in Denmark, and Denmark's GDP last year was about $400 billion. Well, the valuation of this company in the last 2 years it's $500 billion. So this company is worth more than the whole GDP of the country that it is based in. It's just unreal how much this medication has blown up and has really disrupted the many fields, as you'll see. So I'm going to try to dumb down what exactly a GLP, glucagon-like peptide 1, what is the peptide, what are these receptors. So anytime we eat food, I'm actually going to hop down here so I can point out. Anytime we eat food, food stimulates our intestines to create what's called GLP-1. It's a protein. There are specific cells in our intestine that create this peptide. That peptide gets released into the bloodstream on the other side of our intestine. And from there, this peptide, 25% of it goes to our liver. And there are receptors for this peptide in multiple parts of our body. But in particular, we take advantage of the receptors in the liver and the receptors in the pancreas. And those effects, we call them incretin effects. They increase the amount of insulin in our bodies. And that's why these medications are great for diabetes and for weight loss, because they increase our metabolism with their effects in the liver. Interestingly enough, we've also found that there are receptors for GLP-1 also in our brain. And that part of our brain is also responsible for our cravings, for when we're hungry. And we don't quite know for sure yet if this peptide made in our intestines is actually crossing what we call our blood-brain barrier and acting directly on the brain, or if there are just nerve endings in our enteric nervous system that coat our entire innards, if it's just stimulating those nerves, and those nerves are acting on our brain. But for one reason or another, we know that it impacts cravings, or we suspect that it impacts cravings in our brain. And so just remember the peptides produced in our intestinal mucosa, and the receptors that are in our gut, they're also in the liver, the pancreas, and other parts of our hypothalamus. And for those clinicians in the room, I really wanted to explain this because it also explains a lot of the adverse effects that happen with the medication. One being it can cause elevations in our lipase, in our pancreas, and two, it causes a lot of dysmotility in our gut. And when this peptide binds there, it slows gastric motility. And so you see things like potential bowel obstructions, people having constipation, and we utilize that actually for weight loss. And so we think that it decreases the flow of our digestive system, and in doing so, we decrease the amount of food that we eat, along with potentially having this impact in our hypothalamus that reduces our cravings. So these medications have been FDA approved both for diabetes and for obesity, as I had mentioned. There were early studies around the time that these were FDA approved, and I really just wanted an excuse to put this cute mouse on a slide. But there were mouse studies showing that when they have semaglutide in their systems, this procedure that they call drinking in the dark, the amount which is kind of a binge alcohol situation for mice, that they actually reduce the amount of alcohol that they were consuming in this model. And so that struck a lot of people's attention. And then not only that, but if anyone's been on Twitter or on any social media platform, or if you're in the know of this medication, you've seen these headlines. Weight loss drug with Ozempic or Wegovy may reduce desire for alcohol in some patients. Or a man who lost 80 pounds also lost his desire to drink alcohol altogether. We're seeing a lot of this, but this slide summarizes everything that I wanted to talk about today, not only because it was written by my boss at NIDA, but also because I think it's the truest statement. The GLP-1 receptor agonists are promising but unproven treatments for alcohol and substance use disorders. So I wanted to go through all that preface to highlight why it's possible that this medication can work for diabetes, for weight loss, and even for craving. And in that craving realm, these are medications being tested for multiple substances. And so the promising part from the start, so semaglutide for alcohol use disorder. We know from human studies and post-mortem studies, studies looking at people's brains after they've died, that alcohol, people with chronic alcohol use have decreased GLP-1, the decreased of the peptide, but increased amount of the receptors in our brain, meaning that they are not stimulating those receptors as much. So there's a possibility that there might be a way to intervene in which we no longer have the cravings that are associated with when you drink the alcohol. That's a little confusing, and it's okay if that went over your head, because it honestly partially goes over mine as well. But it still is unproven. So semaglutide therapy for alcohol reduction trial, the STAR trial. This is a trial where I'm seeing patients in my capacity at NIDA. We are looking at multiple different endpoints. We're looking at safety and tolerability. We're also looking at efficacy, things like how many drinks per week are people consuming. And we're also looking at interesting things like cue reactivity, which essentially is putting someone in a bar setup, asking them to sniff their alcohol of choice and telling us how much they want to consume that alcohol. That compared to their favorite snack or compared to water. And it allows us to get an unbiased sense for how much this person is actually craving alcohol. And this study in particular goes out to 5 months. And so we do not have this data yet. We've had around 10 patients enrolled. But stay tuned for that data. So it's still unproven, and there's still numerous other studies that are ongoing currently looking at semaglutide in alcohol use disorder. So please reference, I reference clinicaltrials.gov a lot in my slides. Anyone is welcome to go there and search other studies that are ongoing. One thing that is promising, though, is a GLP-1 receptor agonist called exenatide. This was tested in a setting in patients with prediabetes. And actually, this was done in Houston. Is anyone from the Houston crew that did this study in the audience? I saw kind of a hands up. Not from Houston, but not on the study. Anyway, this was a pilot randomized controlled trial, had 84 patients, and it was patients with prediabetes who were also smoking. Everyone got nicotine replacement. Part of the group got exenatide as well. They noticed that there was increased smoking abstinence, 46% versus 26%, but it wasn't quite statistically significant. But of note, there was decreased end-of-treatment craving among the exenatide group. And almost more importantly, there was decreased end-of-treatment body weight. So we may see this as a potential tool. One of the biggest things I hear my patients say about quitting smoking is, I don't want the weight gain that always comes when I quit smoking cigarettes. This may be a potential therapy in the future in which we can reduce the risk of weight gain for our patients that are quitting smoking. A promising substance, but with the least amount of proof, is for stimulant use disorder. It's interesting that some of the earliest preclinical studies in addiction were on cocaine use. So mice that they exposed to cocaine, they were able to show a slight reduction in cocaine use. But they're really, I haven't seen any translational research in this realm. But it is, given the mechanism of action of these medications, there's reason to believe that it may have an effect on stimulant use. And I just recently saw an abstract from a conference in which there was a study of 10 patients who were on medication for opioid use disorder, on buprenorphine or methadone, and it showed that patients who were on liraglutide had reduced cravings for opioids while on MOUD. So this might be another realm where we see this in the future. So our best evidence is in smoking cessation. There's compelling evidence that these medications are going to work for alcohol use disorder, and be on the lookout for stimulant use disorders and opioid cravings. And with that, I'm going to hand it off to Carlos.
All right. Thank you. Is that yours? Thanks, Nick. Is my mic live? Okay, great. All right, thanks everybody. Just to kind of reiterate what Nick said earlier, I sometimes feel like part of our job is to kind of be a buzzkill for people about exciting therapies. But I'm going to do my best to kind of give you a whirlwind tour of the status of psychedelic medicine research, clinical trial research in substance use disorders. So a couple caveats. This is focused simply on substance use disorder, not some of the other known applications that we're talking about, like depression, PTSD. We're just looking at clinical trials that are related to substance use disorders. And also, there are a few psychedelic or psychedelic-like compounds that we don't cover. DMT, mescaline, and MDMA I'm not covering in this talk, mainly because there's not a ton of data out there that have been kind of published that meet a criteria for what we'd call a controlled trial. So with that caveat, I'm going to launch in. And again, to reiterate, my reported conflict is with a company that was listed on the first slide. And full disclosure, I was the principal investigator on one of the devices that we're going to talk about here on one slide. So that graphic, pretty hockey stick, showing the explosion of interest in researching and publishing on psychedelic treatments. This would encompass really all treatments, including the mood disorders and PTSD. But as we can tell, there are just a huge proliferation now of interest and publications in this space. And if you notice off to the left, the other little peak there was kind of during the heyday of clinical use and research of psychedelics back during the 60s and 70s that came to more or less a screeching halt in the early 70s with the passage of the Controlled Substances Act, pretty much making all psychedelics Schedule I drugs, therefore illegal, quote unquote, no medicinal use, okay? So fortunately, we've been able to make some progress. And why hallucinogens? Why hallucinogen therapy for SUD? Well, there's a lot of promise here. Just kind of think about it as a clinician. It's not a replacement or an aversive therapy. It has little to no tolerance or withdrawal effects associated with its use. There's an extremely low abuse potential, practically no abuse potential for some of the classic hallucinogens. Relatively rapid response to single or limited numbers of treatments. So people are reporting lasting benefit from one trip, right? And then a potentially long tail of treatment effect, which is seen specifically with depression, an enduring remission of symptoms, and in some cases, complete remission of symptoms. So the promise of hallucinogens is quite large as it applies not only to these general mood disorders and anxiety disorders, but potentially to substance use disorders. So we're going to kind of launch in. The big four that I'm going to be reviewing here are psilocybin, LSD, ibogaine, and ketamine. And some of them have, well, they're pretty different compounds. We're going to kind of go into that a little bit. But those are the ones that have essentially the most data and the existence of controlled trials to support claims of efficacy. So starting with psilocybin, it's a fungal-derived hallucinogen. There are over 200 species of fungi that contain psilocybin or psilocybin compounds. They grow wild throughout the world. Just about every continent has some psilocybin mushroom growing on it. The active ingredient is psilocin. Psilocybin itself is biochemically inert. It's converted very rapidly into psilocin, which is the psychoactive compound, the hallucinogenic compound. It's known as a classic psychedelic. Those primarily work on what we call 5-HT2A agonists. Those are serotonin receptors, a subtype of serotonin, along with LSD, mescaline, and DMTs. So those are kind of that grouping of very highly serotonin specific with some dopaminergic activity hallucinogens that we all kind of know. Albert Hofmann, considered the father of LSD, first synthesized it in 1958. Its mass production capacity has increased tremendously since 2020. So when you think about how you're going to make it a medicine that can actually be, prescribed at scale, you're not going to be growing, 10,000 acre mushroom farms, right? You have to have a way of being able to actually synthesize the compound, and then once you synthesize it, how to make it at mass, right? So as of 2020, techniques have been developed to where it can be produced in kilogram scales, which then now you're really talking in terms of being able to actually make it into a medicine that can be prescribed at scale. It's experienced a resurgence in interest really due to a landmark 2006 study. It was a well-designed placebo-controlled trial establishing psilocybin and its relationship to mystical experience, and it also corresponded to improvements in what we consider to be a stable characterologic trait of openness and intellect. So if you know kind of psychological typing, there are certain types of stable traits that people have in terms of openness or neuroticism, et cetera. Openness and intellectual openness is considered to be more or less a stable trait. This experience, for some people, actually shifted them a significant direction into being more open in terms of their fundamental disposition to new information. So that really created a huge buzz and interest. Subsequent studies applying to depression, end-of-life depression related to end-stage cancer were published, all with pretty impressive findings and well-controlled trials, most of them coming out of Johns Hopkins. So just to summarize, and again, we're looking just at clinical trials in which there was either a control group or some kind of blinding, okay? A lot of the data out there, a lot of the published reports on all psychedelics are more or less case report or retrospective analyses. So we're just really looking on the ones that kind of pass to a certain evidence threshold. So in all the published reports through really, I guess, about 2019, 3 trials for alcohol. We saw significant reductions in heavy drinking days in all 3 trials. I think, Nicholas, in one of your rapid fire slides, and then a comment I made during the panel, this idea of reduction in use, I think, is an underappreciated outcome in most clinical trials for substance use. So sustained heavy drinking days, sustained reductions out to 32 to 36 weeks, so quite a sustained effect. And one trial with 6-year data reported 32% with complete abstinence, 32% abstinent for 6 to 12 months consecutively. One trial out there, pretty small, N of 15 for tobacco, 7-day point prevalence of abstinence from smoking at 26 weeks was 80%. This was biomarker verified, so it wasn't just self-report. They actually did some testing to check for metabolites of nicotine in the system. And at 1 year, 67% at 1 year and 60% had a mean of 30 months of smoking cessation. And now moving on to LSD, lysergic acid diethylamide. Again, Albert Hofmann, the father of LSD, was developing it for Sandoz Laboratories, was trying to find treatments for postpartum hemorrhage, of all things. Came into incidental contact with the compound, and kind of the rest is history. He tells this amazing story of having synesthesias and spiritual awakenings, and it kind of caught fire. It was branded actually by Sandoz as a medication, under the medication name Delicid, and it was used for clinical research applications. At that time, there was a well-established tradition in just regular psychiatric practices of taking new compounds, taking medications, and giving them to your patients, okay? Got this new thing, you want to try it during one of our therapy sessions? Sure, doc, why not? So they'd do this, and they'd publish a little case series, right? So there's this accumulated evidence base for its use in psychotherapy, just based on a lot of psychiatric practitioner use and publication. Another interesting point in terms of why the hallucinogens kind of pose an interesting research and development base is because if you look back at the 50s and 60s and 70s, you don't really have mouse models or anything like that. They were developed around this. You know, we talked about mouse models for these GLPs. A lot of this is just based on human experience, right? We didn't really do a bunch of mouse studies or anything like that before we decided to start using this in humans, right? So the prominent mechanism for LSD is, again, this 5-HT2A, which is very kind of central to the classic hallucinogens, and some dopamine and D2 receptor activity. And most of the randomized control trials, in fact, all of them occurred between 66 and 73. So we're going back, even before I was born, believe it or not. So as far as summarizing, we have 7 trials for alcohol. 4 of 7 used an active drug control. That's actually important. We're going to talk about this a little bit later in terms of the problems with blinding these studies. So some of these trials used ephedrine, a stimulant, dextroamphetamine, a stimulant, sodium amytal and methadone, kind of a combined depressant and stimulant, and low-dose LSD as controls. And in the active control trials, 3 of the 4 trials actually showed no sustained between group differences, okay? So those are important findings. And then there's only 1 trial that passed muster for heroin. It was no active drug control. It was in an incarcerated population. So got to wonder about informed consent there. And significant improvement, although they did report a significant improvement in total abstinence. Again, not clear as to whether or not these people were in controlled environments or not. But, and again, the level of reporting and standards for reporting findings at the time these trials were conducted are certainly not at today's standards. Ibogaine. This is actually a very interesting compound, kind of a messy drug, but in some ways messy can be good. It's a plant-derived indole alkaloid. T. iboga and V. africana are the 2 kind of shrub-like plants that this derives from. It's used sacramentally in some West Central African, someone will have to correct my pronunciation. I want to say Bwiti. I've also heard Bwete religion. And it's very much an experiential cleansing type of spiritual practice in which individuals will basically have incredibly high recollections of huge swaths of their lifespan. It can be very profound. It was initially approved in France as a neurostimulant called lamberine, but was taken off the market due to safety concerns and the fact that people may have been having too good a time on it. Wide-ranging pharmacologic mechanisms, and I'm not going to go in great detail, but it does a lot of things. It inhibits the serotonin transporter. It also works as a 5-HT2A agonist, like a classic hallucinogen. It also inhibits the dopamine transporter, which could translate into mood effects and reduction in especially cocaine craving. And it's an NMDA agonist, which again can lead to some reductions in opioid withdrawal and can act similar in that case to a medication like ketamine. It's also a partial agonist at 2 critical opioid receptor systems, which again gives it some potential use in opioid withdrawal management and chronic opioid use disorder. As far as trials, there are 4 open-label trials, about 259 participants, all aggregated together, looking at opioid and cocaine use disorders, showing some significant reductions in withdrawal scores, reductions in heroin and cocaine craving, and depression scores, with no serious adverse events. 3 studies were only single-dose studies, so no repeat doses, just one-dose trials. And then a couple of double-blind placebo-controlled trials, about 52 subjects, significant reductions in cocaine craving, reduced cocaine use, but non-significant reductions in opioid withdrawal scores, and a dose-dependent QT prolongation. So what that means is, on your heart, the QT interval essentially is an important beat in your heart rhythm. And if it gets too long, you can actually lapse into some kind of arrhythmia. That has been the most concerning side effect of ibogaine treatment. There have been case reports of people having cardiac complications, some fatalities even associated with acute ibogaine administration and cardiac toxicity. And last one, ketamine. Developed in 1964 as a replacement for phencyclidine, also known as PCP, as an analgesic and anesthetic. Yes, PCP was used as an analgesic and anesthetic in medicine for a long time. Has been used informally or off-label in psychiatry for a long time. There are a number of luminaries in the field of ketamine-assisted psychotherapy and use of ketamine off-label for psychiatric applications for quite a long time. It's an NMDA receptor antagonist, again, increasing release of glutamate. It's a Schedule III drug, so out of all of the ones that we just mentioned, it's actually existing as a prescribable controlled substance, as a Schedule III. So it doesn't even require an additional reporting requirement that you would see with a Schedule II drug, like an opioid analgesic or a stimulant. A non-physician can prescribe it, for example, as well. The intranasal S-ketamine formulation is what's FDA approved for use for depression, but it's also available as an intravenous infusion or an intramuscular injection. So it makes it very easy to use. There's also a very low side effect and safety profile, or very, very low safety risk with the medication as well, especially at the doses that we use for psychiatric treatment. So just to summarize, there are more recent trials of ketamine for alcohol. We look at some positive benefits, reported 68% to 70% one-year abstinence rates in earlier trials. More recent trials reported significant reductions in drinking days, significant sustained abstinence, and also perhaps some signal for alcohol withdrawal management as well. And I threw this one in here, it's not a true control trial, but seems to lower the need for sedating benzodiazepines in the treatment of alcohol withdrawal. Also, 5 studies for cocaine. Again, significant reductions in self-administration, cue-induced craving, enhanced motivation to quit, and then a large short-term abstinence effect in one trial. And when you think about how little we've had for the treatment of cocaine, this certainly has got people interested. Opioids, looks like a dose-related reduction in craving and abstinence outcomes, both early and long-term. Lower medication demand, again, and acute withdrawal. So like with alcohol, you might be able to incorporate ketamine to lower opioid withdrawal stress if you're trying to wean somebody completely off opioids and not start an opioid replacement therapy. And so this is just kind of a handy table that I put together, kind of trying to summarize all this stuff. by class, mechanism, duration, risk, dose, ease of use, and the substances that have been studied in the area. Drawing your attention just to a couple things. In terms of duration, you just kind of look at the differences between these. Psilocybin, you're looking at about 6 to 8 hours of kind of active influence, if you will, of the drug. LSD, 8 to 12 hours, so long day at the office on LSD, okay? Ibogaine, up to 72 hours, so it's a real ride that you're on. And then ketamine, half hour to 90 minutes, okay? So when you're thinking about what you're going for, when you're thinking about what kinds of experience you're trying to foster in your clinical encounter, in your therapeutic encounter, and what you can support as a practitioner in the context of a practice, these durations really do make a big difference, right? Also, what about dose? Pretty wide range in terms of what's been studied. So if you look at psilocybin, these clinical trials, you've got doses between 6 milligrams and 40 milligrams. LSD, 20 to 800 micrograms, right? Standard dose is somewhere around 150 to 200, commonly accepted. Ibogaine, huge range, 20 milligrams to 1,800 milligrams of the medication in different clinical trials. Ketamine, the S-ketamine, the intranasal that I referred to, is either an 84 milligram or a 56 milligram strength. And then if you're using it intramuscularly or through an IV infusion, you do it by weight. So it would be either, in most studies, you're looking at a range of about 0.4 milligrams, almost half a milligram per kilogram, on up to 2 milligrams per kilogram. So we're still at a point right now where we kind of haven't agreed on what dose should be for a lot of these compounds. And then this is kind of my self-rating, ease of use. I'm thinking about this as a clinician, right? So if I'm thinking, what's the easiest one of these to use? Ketamine, high ease of use. To something like Ibogaine, 72 hours, might have some cardiac toxicity. This is an all-in type proposition, probably an inpatient type of thing, right? And so those are just some general guidelines to kind of give you an idea about how these can be applied clinically. And then on the far right, those are the substances that have been studied up to now. And then this is just a quick review of clinicaltrials.gov. If any of you don't know about that website, if you want to just know what clinical trial is currently approved and going on right now, look them up. Easy keyword searches, you can put pretty much anything in there, and it'll pop up with pretty much any clinical trial that's either recruiting, ongoing, or recently ended. So if we look at the activity right now, and this is basically covering the time span between 2022 and now, most of the activity is around psilocybin for alcohol, opioids, cocaine stimulants, tobacco, nicotine, one cannabis trial, and ketamine. Alcohol, opioids, most of the opioid studies that are currently recruiting or ongoing are related to pain. And so in some way, whether or not ketamine can be used to mitigate or lessen or replace opioids for pain. That's a mixed bag, depending on what perspective you're coming from. But that's how a lot of the ketamine for opioids is being tested right now. And then some trials for cocaine, which hopefully we'll see more of, and tobacco, nicotine. Okay, yeah, so as far as challenges go, blinding, okay? So hallucinogens are one of the few compounds that if you take, it's gonna be hard to not know that something has happened, right? So if you're trying to design a randomized, double-blind, placebo-controlled trial, the blind part is pretty hard to accomplish in these studies. So in some trials, for example, the ability for study staff and subjects to correctly identify the hallucinogen condition is like 95%. Okay, so that's a big challenge. And so it begs the question, are there reasonable alternatives to these randomized double-controlled trials? Do we use active controls that are a little bit more hard to differentiate, or lower dose, same drug controls? So that's an area of great interest and deliberation right now, and how you effectively blind studies like this. MDMA, for example, for PTSD, almost certainly going to be approved within the next year or two. I mean, they got around it. They were able to get some really solid studies published, placebo-controlled studies, or using an active antidepressant control condition in order to get these medications across the finish line. So it's not insurmountable. And to that point, expectation effects are very significant as well. Both both investigators and subjects, people who are lining up to do a study like this, they walk in really expecting something special to happen, okay? And again, that's not something you really want in a randomized double-blind placebo-controlled trial. Ongoing Schedule I classification, of course, severely limits research on these compounds. And to some of the points I touched on earlier, lack of consensus on dosing, right? What's the right dose to use? For what condition? Is one dose good for depression and another dose is good for alcohol, right? We just don't know. Study design, as I mentioned, the problems with blinding. Emphasis on preparation and integration. There's a school out there, kind of the more psychedelic-assisted camp, who place a lot of emphasis on preparing people for the experience, guiding the experience, and integrating the experience. And that's in opposition to what we call a psycholytic camp, which just believes it's only the medication, right? That you get the medication in you, and your brain somehow knows what to do, and you don't need any of that other stuff, right? So there's a lot of back and forth about that. And the primacy of the mystical experience, right? We don't talk about mystical experiences with Ozempic, right? You just want to lose some weight and lose your cravings, right? But there's a strong belief that the mystical experience is an or the active ingredient of the treatment effect for hallucinogens. That has not, of course, been proven nor disproven, right? So it's still a very open question. So we're going to shift gears to a couple of devices in development for the treatment of substance use disorders. I'm focusing just on deep brain stimulation and transauricular neurostimulation. Not included in here are things like deep brain ultrasound, certain types of wearable devices that can measure anxiety and stress that might be antecedent to drug use. I'm not measuring apps, for instance, that leverage contingency management, gamification, or cognitive therapy to help people in recovery. Just looking at a couple of devices, okay? So deep brain stimulation, this essentially is what it is, okay? You're putting electrodes that provide very low voltage current to highly targeted brain regions. It's been used for the treatment of Parkinsonism, severe obsessive compulsive disorder, and certain movement disorders, in some cases very successfully. About 160,000 people, more or less, have had deep brain stimulator treatment, not SUD related. So far, there are only about 40-ish people who have been in the literature treated for a substance use disorder with deep brain stimulation, okay? So it's a tiny number of people who've been treated at this point. With some initial positive results, the issue, of course, needs way more data to be able to substantiate it as being an actual treatment. Also, questions around coercion, informed consent, body autonomy, whether or not there are any long-term effects on mood or cognition, right? Those are all very real concerns that are related to this technology. We can say from the 160,000, right, that have been treated for other conditions, as far as safety or long-term downsides for mood and cognition, probably not, right? It's really just a question of hashing out what the implications are of consenting to deep brain stimulation and what the dynamics are around informed consent for such a treatment. And then lastly, transauricular neurostimulation. Basically, it draws on some prior literature that demonstrated increases in endogenous opioid activity with stimulation of branches of certain cranial nerves, vagus nerve and trigeminal nerve. The belief is that if you can stimulate these branches that are located in the ear, that you can actually increase internal opioid tone and thereby reduce opioid withdrawal suffering, essentially. In a controlled trial that we did a few years ago, N of 31, demonstrated a significant reduction in acute withdrawal scores, 30 and 120 minutes sustained through day 5, and it has been FDA cleared for treatment of opioid withdrawal as an adjunctive treatment. It's not a standalone treatment. It's to be used in conjunction with other medication supports. And there are some NIDA-funded trials of TAN for neonatal opioid withdrawal, which is of great interest, like a little tiny baby ear size electrode, looking primarily at number of NICU days, reduction in use of comfort and other sedating medications to manage opioid withdrawal in infants, and also a multi-center funded trial evaluating long-term efficacy of TAN in a more robust sham condition. And okay, test time. Are people actually entering? Okay, we're good, okay. Which of these is not, I repeat, not a classic psychedelic? LSD, ketamine, psilocybin, or mescaline? A classic psychedelic.
We've got some range of opinion, but about 60% say ketamine.
Good. You win the Cupid doll. Ketamine. Ketamine is not a classic psychedelic. The classic psychedelics are LSD, psilocybin, mescaline, and DMT. All right. So, okay. How are we for time in terms of Q&A versus rapid fire? Great. We're doing well. Yeah. Yeah. So what do you think? Do we want to open for Q&A?
Let's do Q&A if you're good with that.
Great. Good. Cool. Should we take a seat or stand? Or?
I heard some ahs. I can go through this rapid fire in 2 minutes if you guys want.
Yeah, do rapid fire. Yeah.
We'll make it rapid.
Let's do rapid fire. What are you looking for?
Oh, the other mic's right here. Here you go, Jen.
Oh, yeah, there's the other mic. Here, I got it.
All right. A rapid fire. Be on the lookout for spironolactone. That's currently being tested as a medication used in heart failure and usually in liver disease. That's a mineralocorticoid receptor antagonist. Looks like it might have some effect on alcohol. Stay tuned for that. Varenicline, also known as Chantix, currently investigating that in alcohol use disorder, also stimulant use. This is my opinion and a lot of other clinicians that I speak to. Naltrexone for stimulant use, because why not? Because it can help prevent people from overdosing. And we know that there's a little bit of effect that we've seen in the ADAPT trial with naltrexone plus bupropion. But speak to a clinician about that, definitely not. It's more, talk to John Weems about it. I'll just leave it. New outcomes for drug use research. Like Carlos said, we are opening a new frontier of addiction research where we are no longer saying abstinence is the sole outcome. So it's time for us to rethink how we're doing a lot of our studies. So those of you in the research space, please consider checking out this. And I also just wanted to give a nod to this amazing article that highlighted that abstinence-based programs actually increase your risk for overdose compared to anyone that's been exposed to medications for opioid use disorder. And I'm not even going to bore you with that. And that was our rapid fire.
Woohoo!
There's another, check out this slide if you want to see other things in the pipeline.
So we have now 8 minutes? We have 8 minutes for
Awesome.
questions.
2 minutes.
Can I, folks can come to the mic if they have a question. Can I just ask one just to start off? What are your thoughts on stimulants for stimulant use disorder?
I saw that question about Vyvanse in the Hoover app. It is something where we do have some studies showing a positive signal. And I just think it's something that we still need to have more rigorous studies to help parse it out. Do you have any experience in this space?
Yeah, I agree. I think John Grabowski published a lot of earlier stuff on this with some positive signal. I think we do need some better studies on that. That said, clinically, depending on level of support, comorbidities, it could be worth a try, clinically, but you kind of need the right patient, if you will, for that kind of treatment.
And we have a hard time parsing out who are the patients with ADHD that are self-medicating with stimulants versus people that are potentially just using stimulants for other reasons. And there's great reason to believe that people who are self-medicating, that they would respond well, and I've actually seen that with many of my patients.
Yeah, thank you.
I had a question about GLP-1 specifically. Anybody who's had experience or worked in addiction knows that early recovery is just a really difficult time. You're kind of playing whack-a-mole, and you're done with your substance, but now, I have relationships here, and I have food here, and I have gambling, and it pops to different things. And GLP-1 agonist is really cool because it kind of broadly acts against many different addictions, and I think it shows a lot of promise to make early recovery easier in many different ways. But I'm wondering, are you guys aware of any evidence of it being helpful in process addiction specifically, or other addictions that are kind of quote-unquote allowed in recovery?
Interesting. Process addictions, I'm not familiar with the term.
Gambling.
Gambling, okay.
Would be one.
So the studies that I've seen for gambling have more looked at naltrexone and SSRIs, and we've seen some positive signals there. There probably is reason to believe that the mechanism of action of this medication, that it may impact that realm, but the craving element that the GLP-1 receptor agonists act on, I could see that there is maybe a different stimuli. It's less of an internal stimulus as it much in the disease processes that you're describing. It's more external stimuli. And whether or not the mechanism of reducing cravings also works when the stimuli is more external, that's yet to be determined. But I can assure you that someone will answer that question in the near future with as big of a blockbuster as the medications have been.
Can I ask you a follow-up?
Sure.
In terms of long-term safety, do we have anything from the diabetes or obesity literature to point us in a direction in terms of long-term safety?
That exact question, I was thinking about it prior to this talk, because I also get the same question from my patients who are on buprenorphine. How long do I need to be on this medication? Yeah. Well, as long as it takes for your life to transform. With these medications, I suspect the answer is going to be similar. You'll have to be on them as long as it takes for you to adjust your lifestyle and how you eat and how you live your life. It does appear to be safe out to several years at this point. There are different cancers that you need to be aware of that it might increase your risk for. But that specific question, I don't think we have the best answer yet.
Thanks.
And it probably depends on people's goals as well for the medication. If they're just looking for a one-time reduction in weight versus a prolonged reduction. So
thanks.
More to be determined, I think.
All right, I've got a question from the Hoover audience, and I think it's mostly for Dr. Tirado, unless we are concerned that the GLP-1 RAs or others may have challenges in gaining community support or have stigma against them based on their effects. But among the psychedelics, these kind of other treatments that you mentioned, have you observed, or what do you anticipate in terms of challenges with gaining support in the treatment and recovery communities, difficulties with patients or their families maybe being hesitant to engage in their use?
I will say I've seen more face valid acceptance of hallucinogen therapies in the traditional 12-step community than for any other medication treatment, including regular psychotropics. And I think some of it has to do with the fact that Bill Wilson himself credits his recovery to having taken a hallucinogenic compound. It was a mixture of like belladonna, and it was like a high muscarinic, like morning glory seed type gross, teenage hallucinogen. But I think I'm oversharing, but Bill Wilson was widely quoted in terms of attributing his final stage of abstinence to hallucinogen treatment.
I think an interesting similarity between psychedelics and the GLP-1s is these are things that are already having a huge uptake in the lay public. Like a lot of, you hear all about microdosing psilocybin and all these things. And so people are doing it, and now it's important for us to verify if it's actually safe and how to make it
and also the promotion of use for trauma in military and first responders, another huge thing that kind of gives it a stamp of approval.
We've got time for one last question.
All right. Hi, I'm Josh. I'm a grad student in social work at UT. Thank you for this great talk. Really appreciate it. I'm curious, you mentioned wanting to get rid of the expectation effects when you're doing a study, and I could totally see that on the research side, but I'm curious about your thoughts about that on the subject side and the fact that potentially those expectation effects could have a positive outcome, and is there potentially something valid there that we wouldn't want to eliminate and would want to take into account when we're looking at the results?
Yeah, I think that when when we have to design studies that have to pass muster for FDA approval, we want to try to reduce active placebo effect as much as possible, knowing that we're always going to have some degree of placebo effect. So statistically speaking, if you need to have a trial that's sufficiently controlled to be able to account for that. We don't know enough right now. Well, you might know at the NIH level, you guys are so smart up there, what we would consider to be an appropriate power to power your study for, to control for a potential expectation effect. So it would really just be a question of deciding what bar you want to raise, for that.
Yeah,
not to eliminate it. I don't think you'll ever eliminate it, but you can control for it.
And for a lot of the psilocybin, didn't they use diphenhydramine?
One of them was,
one study. Benadryl, so loading people up on Benadryl as well. So you feel something when you're ingesting it.
Stimulants, things like that. We call those an active control.
Yeah.
Right.
Exactly.
Well, wasn't that great? We got all sorts of stuff. Thank you so much.